So I wanted to thank everybody who submitted a project today. We actually had 36 submissions, and as you all saw in the Fab Hall, we had 32 beautiful posters. So of those 36 projects, we had 4 that were chosen for oral presentations that are here today. And so we all want to give them a big, warm welcome. And I didn't introduce myself. I'm Shay, Director of Quality and PI here. And today we're going to first start off with a project by Hisham Shaban, which is spelled right because I fixed it, and Dr. Livonia Francis, and they're going to come up here and go over the multidisciplinary approach on improving quality and patient outcomes. And then, thank you so much. Presentations are about 7 to 10 minutes, and we have 5 minutes Q&A for after.
Good afternoon, everyone. So Hisham and I are going to be presenting, and on our team for this project, it was Hisham, myself, Dr. Nakashbandi. He was our executive sponsor, and affiliations, again, is University Downstate, TWIG, Ambulatory Care, Patient Access, and Managed Care. So for the background for our project, CMS offers incentives for participating organizations that are meeting goals and standards with CMS. And for us, this is the HEDIS measures, and that's the Healthcare Effectiveness Data Information Set, which is set up by the National Committee for Quality Assurance. And with this data set, what they're looking at are domains such as preventive care, routine screenings for common medical conditions, improving health, outcome, and quality, and reduce health costs. So that's part of with the HEDIS program. They look at the quality initiative, see how well we do with insurance payers and ourselves. So what we discovered during our course last year, so our problem statement is we missed an opportunity to do well with our HEDIS measures in the beginning of the year. That was due to with the measures for the participating insurance companies that we have here. Just wanted to make mention of that. Unclear team structures, we had gaps in leadership, insufficient education and collaboration. We also lacked AI-driven technology. We had challenges for patient access to care. We had an ineffective key performance indicators that was hindered, and just addressing gaps in critical items for improving the HEDIS measures and outcomes. All right, so for examine, what we did, we had to understand the payers participating for the HEDIS measures. So our insurance carriers are Health First, Metro Plus, Fidelis, WellCare for Medicare only, and the ACO. We had to understand the frequency of getting the reports. We were getting inundated, getting spreadsheets after spreadsheets. We really weren't sure when we're going to get them, so we're looking at some we get once a month, some we get twice a month. We had to identify a count. When we get the spreadsheets, there could be like 1,000 names on there. So what we do, they give us an MMS, which is missing member services. So for example, if a patient was due for colon cancer screening, they would list those patients. If it's cervical cancer screening, they would list those. If it's well child visit, they would list those. So we would have to separate that out. The missing members are the ones that are due for appointments in a certain time period. So that's on our missing members list. And we just didn't have the resources to really act on such a long list. All right, so what we did for 2023, I can't even see, this is so small. Yes, small. For 2023, I better look here. It's too small. For colon cancer screening, we were at 70%. For controlling high blood pressure, 56%. Well child visits, 0 to 30 months, 74%. And well child visits, 31 to 21 years, 75%. That's for Medicaid. For Medicare, for 2023, care of older adults, medication review, we're at 79%. And medication adherence, 86%. Is this me again? Yeah. Go ahead.
Okay. So part of our analyzation process is that we realized that in order to capitalize on this data and to get the full bonus and incentives that are associated with it, we came to conclusion first that, in our analysis, that there was no scheduling templates, so there was limited availability to engage these patients into care. Secondly, leadership was going through a transformation, a change. So the leadership was a bit fragmented, and the accountability was a bit fragmented. Roles and responsibilities were not defined, so there really wasn't a core group of individuals assigned to this. So roles and responsibilities were not defined and not clear, so therefore our performance was somewhat below average. And then also our FTE count versus the data that was available. We had so much data to review and so much data to reconcile and so much data to capitalize on. We just wanted to ensure that we invest in some staff to capitalize on this data, so that way we get a good return on investment. So for the change, what do? For 46 of the ambulatory outpatient care practices, we actually redesigned the templates. We maximized session availability. We started earlier, we started later. That gave us more slots to engage in this initiative and get patients engaged into care as quickly as possible. Secondly, we identified a team group, which composed of myself, Dr. Francis, physician leadership, managed care to help us with the data, the filtration of the data meetings, the measures, the goals, the star rating, et cetera. And then we also partnered with a group called Twig, who are an AI company who focus on value-based care using AI technology. So what that means is an AI agent would reach out to the patient based on the data submission that we gave to our partners. An AI agent would reach out, connect with the patient, have an AI script, engage the patient for yes or no. If the patient agrees to care and agrees to take the conversation further, the AI uses logic, and then after that logic, off the yes response, it goes to our Twig nurses. There was 2 Twig nurses, so it was a hybrid model of clinical support and also AI integration that helped us quickly engage patients into care and get them onto our schedules to improve our reimbursement and better patient healthcare outcomes. Yeah. So for 2023 and 2024, you can see the comparison. So with the organization of our group, our partnership with Twig, the redesign of our algorithms and our scheduling templates, you can see the increases from a year-to-year comparison. So you can see for cervical cancer screening, there was a 5% increase. Controlling high blood pressure, we went from 56% to 65%. Well-child visits, 74% to 81%. And then for well-child 3 to 21, we went from 75 to 78. So with our partnership with Twig and with our engagement in such a short time frame, we made such substantial gains. And there's more to come for this year. For the Medicare, again, another comparison, as you can see here, for the care for older adults, our 2023 rating was 79%, and then for 2024, we jumped up to 91%. And then for medication adherence, we were at 86%, and again, another increase at 91%. So getting more patients engaged into care, capitalizing on the data, having sustained momentum and strong meetings and holding people accountable will get you these results. For the QIP payments, quality incentive payments, you can see the trend. You can see what was going on from 2021, excuse me, to our 2024 of about slightly over a quarter of $250,000. But you can see the gain, you can see the improve in the star rating. Again, the Downstate overall score for 2024 was $259,000 versus the 2023, which was $118,000. Again, that was only on a 6-month trial, 7-month to be gracious, but imagine what we can do in a full year now that we have everything organized, our partnerships aligned, and our roles and responsibilities identified.
So we did have a transformation, which is great. What we did to and keep our improvement going, we sustained weekly meetings and high-level accountability. We had meetings with the whole team. Everyone had their role to do. We held the staff accountable with their respective assignments and outreach to the patients. We have TWIG develop a dashboard for management and leveraging the AI technology. We had physician and staff buy-in. We included everyone, the medical directors, the providers in the clinics. We included nurses, the whole team to help us with this. We did hire 2 patient navigators. They did a lot of outreach, a lot of scheduling, a lot of balancing, so they were also a great help. And we would focus on measures that we know that were achievable, because we had so many measures. We were trying to look at everything, so we looked at the ones that we could really capitalize on with the resources we had, and as Hisham had described and discussed, we did do some great strides and an improvement and for the quality incentive program. Any questions?
Well, you gotta clap a little louder.
Thank you.
Stay up here just for a second, we'll go this way. We have a few minutes for questions. Does anybody have any questions? All right, let's give it up again for Hisham and Dr. Francis. Thank you so much. Excellent. All right, we're going to go on to our second presentation. Ms. Davis, Ms. Anissa Davis is going to be today presenting Reducing Hospital-Acquired C. diff infections by Implementing a C. diff Stewardship Program. So let's welcome Ms. Davis.
Okay. Good afternoon, everyone. So, reducing hospital-acquired Clostridium difficile, C. diff, by implementing a C. diff stewardship program. I'm the presenter, but the team members were Dr. Nakashbandi, Dr. Anna Plord, Dr. Shannon Walter, and Dr. Abdul Rahman. Our executive sponsor was Dr. Michael Augenbraun, and you guys can see the affiliations. So the background of C. diff. C. diff is defined by the presence of clinical symptoms, predominantly diarrhea, and either a stool test positive for C. diff toxins or detection of toxigenic C. diff or colonoscopic or histopathologic findings revealing pseudomembranous colitis. C. diff is also significantly linked to poor infection control practices and the overuse of antibiotics. The prevalence of inappropriate testing is often due to gaps in knowledge among healthcare providers. Patients can be colonized with C. diff but do not actually present with active infections, which can result in false positives. Due to a knowledge deficit and lack of awareness, providers are ordering C. diff tests inappropriately. This contributes to misleading increase in hospital-acquired C. diff rates. These inaccuracies adversely impact hospital performance metrics and undermine value-based care initiatives and infection control practices. C. diff is a publicly reported measure, and hospitals can be penalized for high rates of C. diff infections through CMS, Hospital-Acquired Condition Reduction Program, and that's a program which reduces Medicare payments to hospitals that fall within the lowest performing quartile for certain hospital-acquired conditions, which C. diff is one of them. Essentially, hospitals with significantly higher C. diff rates than their peers can face financial penalties. To address the alarming incidence of C. diff within the hospital, a C. diff stewardship team was established, led by the chief medical officer, to mitigate the elevated infection rates throughout the hospital. So when we examined the prevalence of C. diff pre-intervention for 3 quarters was 20 cases. In quarter 3, we had 3. In quarter 4, we had 8. And in quarter 1 of 2024, we had 9. So during the analyze phase, we identified some root causes of the increased rates of C. diff. Some of them were infection control practices, overuse of antibiotics, inappropriate testing, overuse of testing, and timing of collection on admission. So C. diff is significantly linked to poor infection control practices and the overuse of antibiotics. Inappropriate testing occurs when clinical symptoms are not present and when a patient may have received laxatives. Overuse of testing occurs because patient and/or providers may test due to multiple episodes of bowel movements which may not have the same presentation as loose watery stool more than 3 times in a 24-hour period. During the change phase, we established a multidisciplinary stewardship team. We started it in March of 2024, and it was comprised of people from infection control, infectious disease, quality team, clinical data analytics, IT, physicians, laboratory personnel, and nursing staff. And this reflected the comprehensive approach to infection management. So during the change phase, we implemented a few interventions that have shown to decrease the rates of hospital-acquired C. diff. So the first thing we did was with the help of data analytics, we formed a list that comes out twice daily, and it tells us patients who have pending orders of C. diff to be collected. And so we analyze it twice daily, once in the morning and once in the afternoon, to try to catch the orders and to have them collected in a timely manner and to have them discontinued if they're inappropriate. So the second intervention was to discontinue inappropriate orders. We worked closely with nursing, as well as the physicians, to discontinue inappropriate orders if the patient is not having symptoms, or if they were on laxatives, or if they have like enteral feeds, to discontinue the order, because then it would be, adversely ordered. And then again, we collaborate with nursing so that we collect in a timely fashion, which is less than 72 hours after admission, on appropriate orders. So this is just a look at orders compared to the amount of inappropriate orders. So the first column is the amount of orders that we saw on a monthly basis, and the second column was the amount of orders that we had canceled because they were inappropriate. So a lot of the months, they were over 50% of orders that were canceled, which helped to decrease the rate of hospital-acquired C. diff. And the common reasons we saw for this were because patients were on enteral feeds, they were receiving laxatives, some of them weren't having bowel movements, and there were duplicate orders. So if the nurse collected on the first order and then the second order somebody collected 4 or 5 days later, then it would be considered a hospital-acquired condition if it wasn't canceled. Another change that we implemented was an IT intervention, which includes prompts for the ordering physicians to review exclusion criteria before they actually place the order. And some of it is just asking them, again, before they place the order, is the patient on laxatives? Has the patient had 3 or more loose, watery bowel movements in less than 24 hours? And is the patient on laxatives, or are they receiving enteral feeds? So if they checked off any of these boxes, they were prompted not to place the order. Again, for the change, we did twice daily assessment of new orders pending collection, and we also cross-checked with new orders with isolation lists that are supplied by infection control. We also speak with nurses on the units at the bedside to please collect within less than 72 hours if the patient is actually experiencing these symptoms. And the IT intervention was just like another stop to review the exclusion criteria and to, prior to placing order, to make the physicians think about, is this really necessary? So our change results, pre and post data, is that pre-intervention, we had 20 cases of hospital-acquired C. diff. And post-intervention, we had 7 cases, which is a 65% reduction in hospital-acquired C. diff infections and a 62.6 reduction in C. diff infection rates. The transform phase, there were benefits and barriers. So the assets was collaborating with an interdisciplinary team. Collaboration and communication is actually the most effective way in decreasing the hospital-acquired C. diff. Communicating with the bedside nurse, the nurse is communicating with their patients and communicating with the teams and the attendings if the orders were inappropriate. Again, communication with the patient, nurse on duty, and the medical team caring for the patient, and the daily C. diff pending collection list and the daily isolation list that were provided by infection control. And just the cost savings of reducing the processing of unnecessary C. diff tests is a benefit, and reduced isolation, which results in increased throughput. Barriers were downtimes. Downtimes interfere with the list distribution, so there's nothing to review, so we don't know what orders are actually placed. Weekends, holidays, and vacations, no monitoring occurs. And it's a little time consuming because it's manual chart reviews and labor intensive. You have to make phone calls, you have to call the physicians, you have to speak with the bedside nurse, you have to ask the patient. And also, another barrier is when physicians bypass the IT intervention for ordering. So they know that the patient didn't have a bowel movement, but they still go ahead and place the order. It's a barrier. So transforming the importance of the C. diff stewardship program, the importance of accurate orders, and the outcomes related to the overall metrics. The project highlights the advantages of implementing a C. diff stewardship program. It results in a depicted significant reduction in the incidence of hospital-acquired C. diff, more accurately reflecting the quality of patient care provided. When you capture an accurate amount of C. diff cases, which is significantly smaller, the hospital can focus on the real root causes for clinical care and implement appropriate interventions. The outcome is of considerable importance because hospital-acquired C. diff is a publicly reported metric that directly impacts several performance indicators, including Leapfrog, Hospital Safety Grade, and the Centers for Medicare and Medicaid Services Star Rating, Value-Based Purchasing Program, and the Hospital-Acquired Condition Reduction Program. A decrease in rates equates to achieving higher scores and reimbursements. And for future state and sustainability of this, we are also looking at implementing a verification stop on C. diff orders by having the infectious disease team review and approve orders before the final submission of the order. Questions?
All right, we'll take any questions. You want to come up to the microphone?
So I'll start with the end. At 3 a.m., how would you get the approval if the infectious disease person is fast asleep snoring?
Well, that's future state. It's not implemented yet, but I mean, that's something that we can think about. But as in pharmacy, there are some antibiotics that need to be improved by infectious disease during off hours, and there's a process. So there will be a process.
All right, thank you. Part of our journey is, the We Care journey is accountability. So one of the barriers you mentioned is just knowing the patient didn't have a BM, but you still put the order in. What would accountability look like for that physician? If you have a monthly list of physicians who ignore the order, would that shame them into compliance, or what would that compliance look like?
Well, one issue that we had is that sometimes the nurses would speak to the residents and they would say, my attending wants this, so I'm placing the order. And I mean, we understand everyone has a superior, so if that's what they said they wanted, but working with the interdisciplinary team, we actually communicate with the attendings. I'm like, okay, can I have your attending's phone number? And we speak to them, we discuss why it's not appropriate, and they discontinue it.
So the clinicians want the right information, right? And that's why sometimes, on the other hand, C-diff order is very easy. Just like when they hear, even a rumor, the patient has diarrhea, C-diff or not. And that's why we're the education. That's part of the actual work. It's not just stewarding the orders, C-diff. It's educating the providers that, if you don't have really three diarrhea, more than three diarrhea, a watery stool, you should not order those tests. And we realize actually maybe that's one thing we need to check. Are the orders for C-diff are going down with this intervention? Maybe it is going down. That's one thing that we need to track.
And also we've brought it to the physician's attention and to team's attention, like during our PI meetings. So they are aware of the problem, and we have seen some months, we have seen a reduction in how many orders are being placed.
All right, any other questions? All right, good job. Very nice. All right, let's give it up for Miss Davis. Good job. All right, next up, we have Jasmine Pack. Welcome. We only met virtually, so come on up. Here we have implementation of the Prepare screening tool to identify social determinants of health in patients enrolled in a medical student-led patient navigator program. Let's welcome Ms. Pack.
Hello, good afternoon. My name is Jasmine. I'm a third-year medical student here at Downstate. I'm very happy to share with you our study done by a great group of medical students and faculty here at Downstate in the rheumatology and dermatology program. Just to shout out our team members, we have Alyssa Carlson, Bailal Nagasi, Callie Sachs, Edaman Cower, Fanyu Hercules Tawe, Gabriel Cruz, Grace Shadid, Hadar Shimshan, Maria Botera Pinzon, Meenakshi Kurup, and our executive sponsors, Dr. Sharon Glick and Dr. Ginsler. To start off, social determinants of health are the conditions of environments where people are born, live, learn, and work. Inequities and social determinants of health within underserved communities can manifest as barriers to high-quality health care and exacerbate disease progression. And identifying specific social determinants of health affecting patients in these communities is a critical step towards improving health outcomes and promoting health equity. Without consistent screening tools, however, social determinants of health data can vary widely between providers and institutions, creating a gap between the care provided and the patient's needs. So to provide some background, nationally, African American or Black, Asian, Hispanic American patients with systemic lupus erythematous, or SLE, have high disease severity, complications, and mortality rates versus non-Hispanic white patients with SLE. In the dermatologic population, African American, Black, and Hispanic patients with conditions such as hidradenitis suppurativa experience greater disease severity and prevalence versus white patients. And a 2024 study on social determinants of health in the lupus nephritis population highlights that the presence of 2+ adverse social determinants of health factors, most specifically Black race, care fragmentation, and public insurance, have a 12-fold multiplicative effect on the negative health outcomes in patients. The Downstate Dermatology and Rheumatology Patient Navigator Programs is a medical student-led program established in 2021 and in 2022. So it started in 2021 with the rheumatology department and the dermatology department in 2022. And in this program, we pair medical students with clinic patients who are identified to need additional support. And what that'll look like would be patients with severe disease manifestations, poor adherence to meds or appointment attendance, and or language difficulties. So fellows and attending physicians would identify these patients and pair them with a medical student. And to characterize our patients, 86.6% of the patients in our program are of Black or African American, Caribbean race, and 72% of the patients enrolled in our program have public health insurance. We found a standardized tool for screening social determinants of health, the Prepare assessment tool, which stands for the protocol for responding to and assessing patients' assets, risks, and experiences. This was developed back in 2013, where the National Association of Community Health Centers, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association, they collaborated to develop a national patient-centered social determinants of health assessment tool that is standardized across the ICD-10, LOINC, and SNOMED coding schools of thought, and key criteria for developing this tool included the burden of data collection, actionability, and sensitivity. In 2015, the tool was piloted in select EHR systems in the country, and from then on, it has become nationally utilized. And in 2019, the annual Medicaid Managed Care Survey identified Prepare as the most commonly used social needs screening tool by Medicaid managed care organizations. And the survey has since been utilized in many published studies. I just searched, it was 31 as of today. And the Prepare screening tool offers a standardized approach to assessing 15 core social determinants of health domains, with the core domains being personal characteristics, family and home, money and resources, and social and emotional health. The administration of the survey presents an opportunity to design targeted interventions aimed at improving healthcare outcomes for our screened patients. So our objectives for the study were to utilize the Prepare standardized screening tool to collect data on the specific social determinants of health affecting the patients, to identify barriers to care that they experience, and to curate targeted resources for our patients. So in a recent data run back in May of 2024, we found that within the patients in our program, the most common rheumatological conditions were lupus at 53.6% and rheumatoid arthritis at 31.24%. And in our dermatological patients, the top conditions were hidradenitis suppurativa at 52% and psoriasis at 26.9%. And the total number of encounters, so any communication between the navigators and the patients, were 716 in total. And the mean of number of counters were 5.44 per pairing, and the median was 4 per patient. And this table shows a breakdown of patient demographics in the rheumatology and dermatology patient navigator program. Where we break down ethnicity, the primary language of the patients, race, median age, and the gender of each patient. Back in May of 2024, we were able to categorize each of the encounters based on the purpose of the encounter, with most of these encounters being prompted by the navigator themselves, but sometimes the patients would prompt the encounter. And the top reasons for encounter that we noticed were appointment scheduling or reminders, which were 40%, and wellness checks, which is when the navigator would reach out to the patient to ask how they're doing, to provide support and ask if they need anything. That would be 19.6%. Addressing patients' active medical issues unrelated to rheumatology or dermatology, that was 14.9%. And the median number of issues that we addressed per encounter were 1.45. To analyze the root causes of severe disease manifestation and healthcare disparities in the dermatology and rheumatology patient population in our program is complex. To have greater insight into the root causes impacting our patients, we decided to administer the Prepare screening questionnaire to identify key social needs that intersect with health outcomes. This comprehensive assessment allows us to evaluate factors such as access to necessities, including food, childcare, clothing, medications, and transportation. And the Prepare questionnaire also allows us to identify more nuanced factors such as housing insecurity, stress levels, feelings of safety at home, work situations, and social support networks. And by identifying these social determinants of health, our goal is to become better equipped to target specific challenges within our patient population, ultimately fostering improved health outcomes. For our intervention, we had our patient navigators phone call each patient enrolled or previously enrolled in our program. We verbally administered the Prepare questionnaire, and if the patient's primary language was not English, we utilized Proprio One interpreter, which is our medical interpretation service utilized at University Hospital, which allows us to provide professional interpretation services. And we would record our responses in RADCAP. As for results, 64 out of 169 patients completed the survey, and the patient population were the dermatology and rheumatology patients who are enrolled in our program. And to visualize the results, I've shown some of our results here. As for insurance, 63 out of 64 had at least one form of insurance, with the majority being Medicaid. And when asked in the past year, have you or any family members you live with been unable to get any of the following when it was really needed? There were like 5 out of 11 had difficulty accessing food, 2 out of 11 had clothing needs, 5 out of 11 had difficulty accessing utilities, and 5 out of 11 had healthcare needs. And in terms of education, the highest level of education, 6 out of 74 obtained less than a high school diploma, and 18 out of 64 obtained only a high school diploma. And as for housing, 63 out of 64 of the patients had housing, but 13 out of 64 expressed housing instability. And as for employment, 35 out of 64 were unemployed, 11 out of 64 were seeking work, and 24 out of 64 were not seeking work. And 13 out of 64 patients had difficulty traveling to healthcare appointments. 3 out of 11 patients saw people they care about less than 1 time per week, and 25 out of 64 expressed being quite a bit or very much stressed. To conclude, the Prepare Social Needs Survey identified both individual and systemic barriers to care within our patient population. We were able to utilize the Prepare screening tool to clearly identify the needs specific to our patients that are easily actionable, with the most commonly identified needs being healthcare needs, transportation, and housing insecurity. A key difference that the survey makes for us as a program is that we previously were able to retroactively assess our patients' needs by seeing what they were calling us for, but by administering the survey, we're able to identify needs using a standardized modality, and with these results, provide guidance for our patients. As for our sustainability plan, we hope to administer the Prepare survey at rheumatology and dermatology clinics for all new patients and current patients. We hope to educate care providers and the administration team about administration of the Prepare survey, and we also have a student-made patient resource guide where we can provide more resources for the specific needs that were identified, and we hope to re-administer the Prepare survey to track changes in social need after providing our services. And we also hope to monitor patient outcomes such as appointment adherence, disease severity, patient satisfaction to evaluate our intervention effectiveness. And currently, the Prepare screening questionnaire results are available in HealthBridge EMR for our Suite B, C, D, I, Empire Clinic, and the Star Clinic, which allows our care teams to provide social determinants of health informed healthcare for our patients. To wrap up this conversation, the social determinants of health affecting our patients are complex and multifactorial, and these social determinants of health, including race, insurance status, and care fragmentation, have a multiplicative effect on disease severity and outcomes. And this is where the Prepare screening tool comes in and can be utilized as a standardized, evidence-based approach to identifying key social needs such as housing instability, unemployment, food insecurity, and lack of transportation, which are key insights into a patient's life that can inform how we care for them as health providers. As a program, we plan to continue our efforts to survey more patients in our dermatology and rheumatology clinics, and we can utilize factor analysis to identify key determinants that are associated with higher disease severity and missed appointments. And for patients that we identify as high risk, we compare them with navigators to address their identified needs. And systematic screening and integration of social determinants of health into HealthBridge can aid in targeted interventions and navigator pairings to improve outcomes. And addressing root causes through comprehensive social determinants of health assessment and intervention is critical to reducing disparities and enhancing patient care. So, thank you.
Social determinants of health is very important to all of us. Do we have any questions? Oh, Jasmine, sorry. Any questions? Mr. Bennett?
I'm sorry. Dr. Nakashbandi, based on the committee that you lead, SDOH, there is a disparity between when the nursing staff assesses the patient. When the nurse does the SDOH, he or she gets a certain score. However, when the social worker goes in independently and assesses the patient, they get a higher score. And I'm trying to figure why is the difference? If we're all using the form that you prepare form, why are we getting different results? And I've been bugged by that question, the concern, Dr. Nakashbandi. I don't know if Ms. Pack can give an insight on that.
Yeah, that's a very interesting question. For example, for one of our questions, asking about like any needs, not a lot of our patients answered that question, and it may be because it's a sensitive topic, and I think that's something that we can explore more on, the differences in the score based on, the environment in which the patient is taking this questionnaire, who is providing it, any language issues that may, be affecting that. So that's a great point.
Do we have any other questions? All right, thank you so much. Let's give it up for Ms. Jasmine Pack again. Thank you so much. All right, for our fourth and final and not but least group, we have improvely timely submission of the MRI safety sheets for inpatients, and we have Jeannie Bonvino, Dwayne Brown, and Cavell Pierre.
I'd like to thank you all for taking your time out to be with us this afternoon. We also like to thank Dr. Jewell for allowing us to be able to present today. Thank you. Today we'll be talking about improving our timely submission of an MRI safety sheet for inpatient. The presenters will be Ms. Jeannie Bonvino, Ms. Cavell Pierre, and myself, Dwayne Brown. Our team members is our executive sponsor, Dr. Tina Rhea, who we drove crazy during this process, but we want to thank you for your guidance. Also, we would like to thank our project mentor, Donna McKenzie, our MRI supervisors, radiology registrars, radiology MRI techs, our assistant director of nursing, Ms. Ruth O'Donnell, and our attending and chief residents, Dr. Masola and Dr. Gahani. We want to thank you deeply. Now, before you can get an MRI done, a safety sheet must be filled out. Radiology should receive this safety sheet within 2 hours of the order. So this was the issue. Only 60% of inpatient MRI studies are completed by 24 hours, and only 10% of the safety sheets were received within the specified 2 hours of the order. So what was our objective? Our objective was to improve overall submission of the MRI safety sheet and improve MRI safety sheet compliance. Our next chart here, as you see, more than half of the safety sheets were received after 10 hours, 58%. And once again, 10% of the safety sheets were received within 2 hours of the imaging order. As you can see, a tremendous opportunity for improvement was identified. So this is what we did. We submitted data from January to June 2023 and used it as our baseline measurement. Here, this is our current state process map, and Mrs. Jeannie Bonvino will speak about the issues that was discovered in this process map.
Good afternoon, everybody. So in order to examine the MRI process, we created the process map to look to see, where our shortcomings were, and then then we met with all responsible personnel involved in the MRI safety sheet process, and we asked the ordering physicians, nursing, and radiology staff what issues they may have with the safety sheet. Although there were numerous issues mentioned from all the groups, lack of communication and workflow awareness were the two main areas. We wanted to know what the safety sheet process was in other hospitals, so we surveyed Kings County, NYU, New York Presbyterian, and Queens Hospital. We asked them the same 4 questions, and aside from all of them having the EMR system that communicates with all other hospital systems, the ordering physician was responsible for completing the safety sheet at the time of the order placement. In fact, their systems don't allow the order to be completed until the safety sheet is filled out. So we use this benchmark data to get buy-in from our ordering physicians, and we summarize the data collected from the voice of the customer surveys and from the process map. These issues were workflow awareness, ownership of the safety sheet, transmittal of the safety sheet to radiology, and the consolidation of the safety sheet. And I'll give it to Cavell to explain further.
So after going through the processes that Jeannie just spoke on, we decided to conduct a pilot to see if these changes would yield any improvement. So we revised the safety sheet. We assigned ownership to the ordering physician. We made sure that there were several ways for the floors to get the radiology sheet down to them. We discussed the project, the process with all the parties involved, and we distributed a contact list, so if any issues arose, that we could be contacted. So as you can see, we made several enhancements to the form, basically including condensing and reorganizing the sheet. As you can see in the first sheet, like the yes and no, some were in the end, some were in the beginning. It was kind of all over the place. But the second sheet, what we did was we tried to align most of them to the left-hand side of the sheet to make it easier to navigate and to fill out correctly. For the first pilot, we saw positive results, with 76% of our sheets being sent within 2 hours, and that was a tremendous improvement from the 21% that we saw in our baseline data. But however, our first pilot was a small sample size, and we also didn't know if the results were possibly influenced because radiology were making phone calls to the floors requesting the sheets. So because of that, we decided to conduct a second pilot. With the second pilot, we did see similar results to the first. We followed the same steps as the first, but we did tell our staff not to call the floors to get the sheets. And with that, we did see a 74% compliance rate within the 2 hours. So both pilots reflected improvement in the accurate completion and timely submission of the MRI safety sheets. The data from both pilots confirmed that sole ownership for completing the safety sheets increased submission compliance within the 2-hour time frame. For our transformation, we intend on continually monitoring the compliance for the next several months to make sure that everyone who is involved with ordering MRIs are aware of the new workflow. For December, the numbers for compliance was 79%, and we also provide monthly radiology PI data updates, and the metric was added to our dashboard. So as you can see, this is our new workflow process, which was included in a center-wide email that was sent out on October 24th, 2024, outlining the changes to the MRI, the inpatient MRI workflow. So basically, we start with the order. The ordering physician then fills out the safety sheet. The safety sheet can then be faxed or emailed to radiology. From there, the radiology staff reviews the sheets. They make sure that everything is okay. The patient will be safe to have this study done. The radiology staff will then reach out to the floor, scheduling them to come down to have the study done. The study is completed, and this should all be completed within a 24-hour time frame, ideally. So from the beginning of our process to now, we transitioned from a dual ownership to sole ownership. We made sure that the floors were able to get us the safety sheets via fax, e-fax, and we also created an email address. We also made sure that all the floors were equipped with working fax machines, and last but not least, we had a contact list, so in case there were any problems and they needed assistance, we can be easily contacted. What I learned from this project was that achieving process improvement requires a step-by-step approach with no shortcuts. The structured outlines that we learned from the Greenbelt training, specifically the DMAIC framework, are essential for sustainable results. Skipping any step may lead to incomplete solutions or temporary fixes that don't address the root cause of the problem.
What I learned that time management is critically important in a hospital setting because it directly impacts patient care, staff efficiency, and overall hospital operations, leading to improved outcomes and reduced stress. And here's why I think time management is so crucial. When we're dealing with patient care, reduced time, wait time. Efficient times management ensures patients receive timely care, leading to faster diagnosis, treatments, and discharges. Now, these are just some of the reasons why time management is important in a hospital setting.
What I learned is that in order to collaborate with cross-functional teams to achieve measurable results and sustain improvements, you must get buy-in from all the people that are part of that process. Thank you. Any questions?
All right, excellent job. All right, do we have any questions? Great job. All right, we'll let our last presenters go. Good job. Let's give another round of applause. All right, well, that brings a finale to our oral presentations. Do we have Dr. Nakashbandi or Lily? Do we have something next?
Okay, good afternoon, everyone. My name is Lily Angie. I'm the Director of Patient Safety. Some of you I met by email, some by phone, some by text. So welcome. I hope you've had a great day. And now for the moment we've all been waiting for. We are here to announce the winners of our projects, posters and oral presentations. So as your name is called, please come up on this side and come across the stage. And we have Dr. Winston and Dr. Nakashbandi will be handing your certificate as well as your prizes. So first winners, and in no specific order, Emma Schultz and Kevin Quirk for their project Analyzing the Prescription Disease Burden of the Patients Seen at the Ancaster Brooklyn Free Clinic. Do we have Emma or Kevin? I'm not sure. They're not here. Okay. All right, well, Dr. Winston's always a winner. Okay, next then is a presentation by Ms. Anissa Davis reducing hospital-acquired Clostridium difficile infection by implementing a C. diff stewardship program. Next, we have Cynthia Lugo Iglesias, improving organizational health literacy in pediatric clinic. One of our posters. I think we're going to revoke some prizes. All right, next up, Jeannie Bovino, Dwayne Brown, Cavell Pierre. Thank you for your project, improving timely submission of an MRI safety sheet for inpatients.
We belong to you.
Okay, and our final winner for today, Ms. Sheila Hippolyte Francis and Ms. Teresa Uva, Blue Bracelet Program, Raising Awareness and Improving Detection and Treatment of Preeclampsia. Please come up.
You know, I gotta take my time. You know what I'm saying? Thank you, Lillian, for all your help. I appreciate you so much.
I just want to say a very big thank you to everyone involved, all the oral presenters. I know you really worked very hard and to really make it happen, and Dr. Shea Walter and Mr. Tyshawn Tony, who also helped push this all along. So thanks for giving me the opportunity and working with me too.
Thank you, everybody, and thank you for those who stayed for the presentations and did the poster session. Everybody did a great job. Thank you.
Thank you so much, Dr. Winston. This is the end of our event. Appreciate everyone attendance. I'm so proud. This is amazing. And this is why Downstate is here. We are the leader in quality patient safety in Brooklyn and in New York City. Thank you, everyone.